Well, I certainly thank you for that invitation, introduction, and I really appreciate seeing such a great turnout. I really appreciate all of you people supporting our program by coming today, so thank you very much. Over the next 25 minutes or so, I'm going to talk about several areas where we're looking at studies that have been done recently that have to do with celiac disease and gluten-free diets. And the three categories are going to be feeding practices, policy, and I'm going to talk about a couple of new reports from the government, and then some new treatments. So first, feeding practices. There's been an increase in the amount of celiac disease, the prevalence that we see over the past few decades. And there's been speculation about why that is, but it's clear. This microphone.
Yeah, you can turn this and it will raise up. There you go.
So I'm still John Snyder, and I hope you can hear me now. On our first topic on feeding practices, there's been an increase in the prevalence of celiac disease in the past few years, and there's been speculation about why that is. And people feel now that it's not due to doing more testing and having better testing instruments, but there's actually a true increase in the prevalence. And so, what is the reason that causes that? And earlier studies have suggested that infant feeding practices play a big role in this, especially breastfeeding, and then the timing of the introduction of gluten. So these are important questions that have been looked at fairly recently in studies. And there's the first of two studies that have been looked at. These were both published in one of the most prestigious of the medical journals about 2 years ago now. And this was a study that was done throughout Italy. They involved 20 centers, and they looked at the time of introduction of gluten either at 6 months or at 12 months, and did that make a difference in the outcome of a child who would get celiac disease. They looked at 553 children, and these children were at increased risk to have celiac disease. They had either DQ2 or DQ8, and they had a first-degree relative who had celiac disease. And it turned out that the prevalence in this population when the study was completed was about 20%. So you know it's about 1% in the population in general. So this was an increased risk population. The second study was also published in the same journal 2 years ago. And the hypothesis for this study was that if you give small amounts of gluten early in life, that you could create tolerance. And that's a term that's used for giving small amounts of a protein that could cause a person problems. If you give small amounts over a period of time, a person is often able to handle that protein, whereas otherwise it would have been a problem for them. And so for this study, it was a double-blind, placebo-controlled trial, and it was done in 8 countries. They introduced small amounts of gluten at 4 months of age, and they did this in almost 1,000 children. And again, this was in an at-risk population of children. They had either of these markers, DQ2 or 8, and they had a first-degree relative who had celiac disease. And so these children received either a small amount of gluten at 4 months of age or placebo, and then they all got introduced to gluten at 6 months of age. So the findings from these two studies showed that it didn't make a difference whether you tried to induce tolerance in the children or whether you gave gluten early or late. Their chance of having celiac disease was the same. And interestingly also that it turned out breastfeeding was not protective for the development of celiac disease. So these are the first big studies done in big populations to provide important answers to these very important questions. And there was a paper that summarized these findings that was published just a couple of months ago. And it included a commentary by the leaders of the group of academics, the people in academic medicine, who are actually the study leaders in celiac disease on this topic. And it raises speculation that if it's not the diet, and when you introduce gluten, what are the other factors? And obviously this is an area of hot research. And the area that's being looked at the most are the bugs in the gut. So you'll hear more about that over the next few years. but it isn't whether you breastfed or not early, and it's not really, it doesn't appear that it's going to be the timing of the introduction of gluten. I'm also going to talk briefly about a commentary that was published a couple of months ago by Dr. Riley from Columbia. And she looked at gluten-free diet and is it a healthy diet for people that don't have celiac disease? And that would be an interesting question to have for the audience today, what your thoughts are on that. But what she did was a careful and thoughtful review of all of the data that's available. And so she looked at issues that have played a role in this rapid rise of the use of the gluten-free diet, and she looked at all of the data available on whether eating gluten itself is toxic if you don't have celiac disease. And it turns out that the data show that it is not toxic if you don't have celiac disease. And it also looked at the potential problems with gluten-free diets if they're not done carefully, that a lot of the foods that are gluten-free haven't been enriched as other foods have been. So one of the take-home points from her paper was the importance of having a dietitian involved in these kinds of diets. And I would say that I would heartily agree with that. I think that's probably the most important piece. And this is the citation if you're interested in looking up her commentary. Now we're going to turn to policy, and there are a couple of policy reports. This isn't so much research, but it has a background in research. So the first of these is a big report that has just come out from a group called the Agency for Healthcare Research and Quality from the Department of Health and Human Services. And this is an agency that has a mandate to provide systematic science-based reviews to improve the quality of healthcare in the United States. And so in February, they published their first paper on celiac disease, and it was a look at how it's diagnosed. And it provides a thorough assessment. If you have the time, I think the total document is about 170 pages, but it has a lot of information about celiac disease, and I provided the link for you if you'd like to read that document. So what's the impact of this document and documents like this? So our colleagues and friends at the Celiac Disease Foundation did an op-ed piece on this survey, and on this report, and they emphasized 3 points. The first is that this big review provides a focus on how poorly we are at finding people who have celiac disease, and you probably know that that number is only about 20% of the people that have the disease have actually been diagnosed. So that's a real problem, obviously, and one that has to be addressed. They had a second point, and that was to feel very positive that the federal government now sees this as a public health problem. And I think that's probably one of the biggest issues about this report, that it really focuses attention on this problem. And their hope from the CDF and others is that this will increase awareness and improve practices that are associated with celiac disease. And this group, this AHRQ, is going to have a clinician summary which comes out soon. I don't want to get your hopes up too high by having a federal government report having an impact on health in the United States. So I hope, so I'm an optimist. I hope that it will. Would it be good if it did? Absolutely. But in practice, does that happen? And there's actually been studies to look at how people change their practice habits. And it turns out this kind of activity doesn't usually have a lot of impact. And so I'm going to call on you people here in this audience to be advocates in your community. So in this group, it's easy because I think you're going to find a lot of people who are going to feel very similar. But in your bigger areas of interest and affiliations with people, be sure to, if you have a friend or a colleague that's having difficulty with a health problem and people are looking for an answer, haven't thought of celiac disease, that's probably good to do. And if you're having problems and your physician hasn't looked at that yet, then be an advocate for yourself about this too. And that turns out to have a bigger impact on changing practices than does a survey like this one from the federal government. Now, again, I'm hoping very much this is going to have a big impact, but I also want to be sure that you know that you're going to have a bigger impact by being advocates in the community. So I'm going to talk next about a second report from the federal government, and this is about the problem of arsenic in rice. And it turns out this is the biggest question that I get from my patients in the past few years. So arsenic is an element in the world. It's everywhere. It's in water and air and soil. And if you are eating foods that have been where they've used fertilizers or pesticides, that also adds to arsenic. But even without those, there's still arsenic in pretty much all kinds of food, and especially rice. It exists in two forms. One is organic, and the other is inorganic. And it turns out that the part that's inorganic, it's fine with me for the baby to stay. If you're comfortable, I'm comfortable. I'm a pediatrician, remember. So the form that we worry about with arsenic is the inorganic form, and it's toxic in the diet. It can be toxic in high levels. And with rice, which is an ingredient in a lot of the foods that we eat, in gluten-free foods, it has an increased amount of this inorganic arsenic. And that's because that product rice does a lot more absorption of arsenic than other crops do. And it's not it's not an additive to rice, it's just part of the inherentness of how it's grown. And you can't remove it completely. You can reduce the amounts of arsenic, but you can't remove it completely. So what did the FDA say about rice and arsenic? So there's a new study that was published in April of 2016, and I have the website on this slide for you to use if you'd like. It found in infant cereals, which is a common form of the food for children to get, that the amount of arsenic in these infant cereals, rice cereals, ranged from 20 to 170 parts per billion. And that was more than twice that of other infant foods. And so they advised parents to use a variety of types of cereal grains to feed young children. And the FDA and the AAP, which is the American Academy of Pediatrics, had set an action level of 100 parts per billion. That above that is a potential problem. So I want to be sure you all were up to date on this and aware of this. So the take home from this is that arsenic is found in foods, a lot of foods, and especially rice. And it isn't an additive, it's just part of how it's grown. And it's, as you know, it's found in a lot of the foods that are used for gluten-free foods. The FDA did not provide any data on consumption of rice products, but consumption itself is not considered a health problem. So I wanted you to be sure, probably the take-home lesson or the take-home lessons is that you want to realize that arsenic is a content, that amount is going to vary. And so you want to be careful on the type of rice products that you're buying, and you're going to see more publication about the amount of arsenic in rice products as time goes by. And so you want to look for products that have under 100 parts per billion of arsenic. All right, so I'm going to move on now to therapies that are new, and I think this is what maybe a lot of people thought I was going to talk about, so I am, but I wanted to be sure we're updated on these other two areas too. So first, some background. There's three major targets for therapies for celiac disease. The first is you would want an agent that would bind or digest the gliadin peptides or the gluten peptides that would be eaten by someone. The second area that you look for as a target would be to block the uptake. So you have the gluten, you didn't break it down, but you don't let it into the cell. And then the third option for therapies is to alter the immune response. So we know that once it gets into the cell, there's a whole cascade of things that happen in the immune system. So that would be the third target, to alter that immune response. And these are the information I'm going to present over these next few slides has come from updates from the DDW, which is the big GI meeting that was held in San Diego only a month ago. So this is a schematic, a view of of how this all works. So you see that golden droplet, those three ones in the, you don't seem to, oh, maybe I do have a pointer here. So this is the protein. This is the peptide from gluten called gliadin, and it's out out in the lumen of the intestine, and so we could break that down or bind it. It couldn't get into the cell, so it wouldn't start the whole cascade. And then a second way you could look at treatment would be to look at how it gets taken up into the cell. And the thought has been that a big part of that is through a problem with tight junctions. And so if you look at these intestinal cells, they look like a bunch of condominiums or houses built very close together. So they're really attached together. And with problems with the tight junctions, that junction between the two houses, it actually opens up and it allows the uptake of proteins like gliadin. And then the final area is once it gets into the cell and it's not altered, then it starts this whole cascade of the immune system. So if you could block that, that would be the third area. So that's this whole set here with things like T cells and different kinds of proteins that affect the immune system. So the first area we're going to look at is to break down the gluten or to bind it. And so the first thing, one of the areas people have done research in recently, and there's a new product that's getting started in the pipeline, is a type of resin. And it's a resin that binds to gliadin, and it prevents its release so it can't get into the cell. It binds it in the lumen. It doesn't get into the cell. So they're just starting clinical trials. The product is called BL7010. So that's a pretty exciting name. I'm sure they'll get a better name later, but that's the name for now. And again, it's a polymer that's going to bind to the gluten and gliadin, and it won't let it into the cell. And there are actually some studies that have been in humans and also in mice that have shown protection to the intestine. So it's not just a good idea, it actually has promise, and it is now in phase 1 trials. A second type of medication or treatment that could be used to help prevent the onset of symptoms with gluten would be to break it down. And so you could use enzymes to break down that protein. And there's a product called ALV003, again, catchy name, but I'm sure there'll be a better trade name later. But this is an oral preparation of 2 enzymes. It breaks down the gliadin into a form that's not active in the cell. So it's aimed at people who have celiac disease, even though they're on a gluten-free diet. There have been some problems with how it's delivered. It's an oral agent that hasn't it has had some problems with stability. It is now in phase 2 trials. So this is one that's getting pretty far down the pipeline. The final level for trials is a phase 3 trial. So this is already past 1, it's past 2A, it's on to 2B. So that's one that you're probably going to hear a bit more about. Because there have been difficulties with these enzyme preparations and their stability and all, people have looked at an alternate way of treating that protein and breaking it down. And so probiotics, you're hearing about that for pretty much everything now. You're going to probably hear even more about that going forward. And this is one of the areas where it may play a role. So the theory behind using a probiotic or bacteria to break down the gluten or gliadin comes from that thought that only about 3% of people who are DQ2 or DQ8 actually ever get celiac disease. So why do all those other people who have those markers, they don't develop it? Why is that? And in the same way we talked about earlier with infants and why infants, it isn't the timing of gluten that appears to be important for developing celiac disease. It's probably the gut flora, or it may be the gut flora. And that's the thought about this. Mm-hmm. So is there something we could do about the gut flora that could alter these proteins? And so there was a study that was reported at the DDW meeting in San Diego last month where they looked at several types of bacteria in a mouse model. And they found that there were groups of these bacteria that could break down that gluten or gliadin into a form that wasn't active. And the reason I mention this study is that the person who did it, her laboratory, and that's Dr. Verdu from Toronto, is one of the top basic science people in celiac disease. So if you haven't heard that name before, it's probably good to write that one down because she's really good, she's really smart, and she's one of the people who's helping to make a lot of the progress in the basic science part of looking at celiac disease. So I don't know if this probiotic is going to be the answer, but what is almost sure is that there's going to be a lot more look at using bacteria to break down the proteins in gluten and gliadin. So how about blocking the uptake? And this is a drug that you all have heard about before, perhaps not the name, but the idea of a drug that's going to tighten the tight junctions. So it doesn't allow those cells to come apart, and it doesn't allow that protein to get into the cell. And this type of medication is called a zonulin receptor antagonist. Really a catchy name, but the person who identified this protein is one of the top pediatric GI people in research on celiac disease, and that's Dr. Fasano, whose name I think a lot of you are quite familiar with, who's up in Boston now. So this is his product. This was his baby, and he has an active investment in this company that's making this this new class of drugs. It's an oral peptide that prevents the opening of these tight junctions. And it's aimed at patients, again, who have celiac disease, who have symptoms, although they're on a gluten-free diet. So far, the impact on uptake has not been as great as people had hoped. And that's because it only works for the tight junctions. It doesn't appear to help with taking the gluten or gliadin across the cell itself. And it's about to enter phase 3 trials. So this is something that's going to be in the marketplace probably fairly soon. And then altering the immune response, this is the last category, looking at vaccines. And so when people talked about vaccines and their impact on celiac disease, I didn't think that was something that was going to happen very soon. But it turns out there's a lot of activity that's happened and a lot of progress that's been made. So this product was also, a couple of posters were presented about it at this meeting in May. And it consists of vaccine that consists of 3 peptides, which are recognized by the T4 cells, one of that part of that cascade of the immune system, in people who have HLA DQ2 positivity and have celiac disease. So it attenuates the responsiveness to those gluten peptides, and it aims to restore the immune tolerance to gluten. Again, tolerance is that idea that you could eat gluten and not get symptoms from it. And to be effective, it looks like it's going to have to take injections into the dermis, into the skin, each week. And I put down the name of the person who is in charge of this project, because I think this is a very innovative project that has a chance to have a real impact. Now, if a lot of you are like me and don't love needles so much, you might wonder about doing these weekly vaccinations. But it's actually quite analogous to what happens with allergy. A lot of people who get allergy shots are getting this exact same treatment. So it isn't so far-fetched, and if it really worked, it could allow people to eat a regular diet and not be affected by the gluten. And it's in phase 1 trials, so it's another thing I want you to be aware of. It's in the pipeline, and it's likely to come fairly soon. And then the final study I'm going to mention is one looking at a drug that's in the trade called Singulair. So those of you who have asthma or have friends who have asthma may have heard of this medication before. It's a medication that's never been used in celiac disease before, and it blocks the effect of one of those immune proteins that I showed you in that earlier slide with that whole cascade of immune response. So it blocks that response, and it doesn't allow it to happen. And there's preliminary studies that show that this Singulair agent, the active agent in it, can block cytotoxic T cells, again, part of that cascade. And it has never been looked at in celiac disease, but there's a big, big amount of data on safety with this drug, and that's a big deal to know ahead of time that you have a good chance that it's going to be a very safe drug, because it's been used in asthmatics for a lot of years, and children too. And so there's a recruitment that's going on now with our friends and colleagues at the University of Chicago. So I just wanted to be sure that you were aware that this was something that people were looking at too. And if you're a little bit of a skeptic or a pessimist in life, you'd say, you know, if they're looking at this kind of drug, it must mean there's not a lot in the direct pipeline that's coming out very soon. And I think there may be some truth to that. But we'll see. And if it helps, and if it helps block that immune response, then that would be a great thing. So I'm going to close now with some thanks. And the first thanks is to Vanessa, who is in the room or not, but I'd like a round of applause. Because I promise you that we could not have this kind of a function without her. And without her energy and her innovation, couldn't happen without her. I also want to thank all of our board members. There are a lot of them you're going to meet today, whether they tell you they're our board members or not. They're here and they're providing a lot of help to make this big event happen. I also want to thank our Children's Foundation. They provided a lot of people to help with the organization of the event, and a lot of volunteers. You see people in these pretty blue shirts, which I didn't get, but they look very nice. And if you see them, please thank them because there are a lot of volunteers who help make this work. And we also want to thank all the vendors because they have been so great. We have had vendors who've stayed with us for the 6 years we've been doing this, but we continue to grow, and we certainly thank their support. And then I want to especially thank you, the advocates for celiac disease in this audience. So thank you very much. I'm happy to answer any questions if there are.
I actually have asthma and I'm already on Non-Celiac. Would the dosage be the same?
So I don't know all of the details of the project, and they're going to do it. They're only going to do it in adults. The age range starts at 18 years, but I think there's going to be a range of doses. So I'm not sure exactly what the dosing is going to be. Yes.
What is the genetic component to celiac?
The genetic component, well, you have to have the predisposition. So you have to have a gene that's going to cause you to react to gluten and turn on that pathway with all those parts that I showed you on that figure. But it's interesting that a lot of the children that we see, over half, don't have anybody in the family that has it. They're the first one in the family that has it. So it isn't like with some diseases, there's a long history of families, it gets passed down from generation to generation. That happens also, but we have a lot of people who are the first one in their family that have ever had it. But you have to have genes. They have not been truly identified yet. There's a lot of work that's being done. There's categories of genes, and that's what those HLA, DQ2, and DQ8, those are a group of genes. Both of them are groups of genes that play a role in developing celiac disease. But it clearly can't be the answer because so many people have those and they don't have celiac disease. But I'm hopeful that we'll have a lot of progress in the next decade or two about what are the genes. It's probably going to be more than one gene that's involved. But you have to have those. We don't know exactly what they are. But when you have those and you're exposed to gluten, that gluten is a trigger that's going to cause the immune system to injure your intestine.
Right.
Yep. As we had a microphone here, we'll get to you in just a minute. Yeah, go ahead.
Okay, so I know that celiac is a genetic disease, and with the development of genetic engineering, would it be able to prevent celiac disease and the gene from appearing in infants before they were born?
So this is one of my patients, so I'm really proud. This is, I'd say a great question. So there's a simple, quick answer, and that's yes. But then the harder answer is, when is that going to happen? And since we don't have the gene yet, you can't really engineer it yet if you don't know exactly what it is. So I think it's likely in your lifetime, as opposed to my lifetime, that that's going to happen. But so yes, a lot of work being done, a lot of work on the discovery of the gene or genes that are involved. And once that happens, then there's a potential for altering the gene. But also these other things I was showing you, there may be some treatments that can, even if you don't alter the gene, and there's always worries about when you alter the gene and what kind of impact that's going to have down the road. Some of these other therapies may end up being very helpful too. And we had a question back here. Yeah.
So you identified what it isn't, that it's not the introduction, it's not the breastfeeding. What's your thinking as to why there is the increased expansion of the celiac disease in the population right now?
So I give a talk every month to the third-year students who are from George Washington and come to Children's, and I tell them that the bravest thing to say in medicine is, I don't know. And it's very interesting how infrequently that term ever gets used. But so the honest answer to your question is, I don't know. But if you want me to speculate, then I I think that the timing of the introduction could have played some role, but it doesn't appear that it did based on those 2 large studies. And so you need to look at bigger picture kinds of things. And so one of the things that I think people are going to spend a lot of time and effort on, and are already spending a lot of time and effort on, is all those bugs that we have in our intestine, and what role do they play? And we're in our infancy in looking at that, but in a number of states of alterations of people's lives, of diseases that affect the brain or the gut or lots of different parts of the body, the gut bugs play a role in it. And maybe it'll be simplistic, but I think this idea, that study I was showing you of those bugs that break down the gluten, that concept of how the bugs set up an environment that let gluten get through or not get through and cause damage or not cause damage, I think that it's very possible that's going to play a role. And because we have a great speaker who's following me who wants to get going too, I'm going to stop with that, but if you want to ask me later or when you see me in clinic sometime, I'm happy to expound more. Great. Any other questions? Yep.
Hi. Can you give some advice for someone who's concerned about gluten in medications? How to find gluten in medications?
So there's actually, so the question I think everybody heard was that question about having gluten in medications. So this is a real problem. And so I'm not political. I'm not going to tell you about who you should vote for president or something like that. But I'm going to tell you that there is a bill in front of Congress that's actually been stalled for about 5 years to make it the law in the United States that drug companies have to identify whether gluten is in their products or not. So I don't know if that makes me political or not, but I would absolutely encourage you to speak with your congressman or your senator and encourage them to support this law. In Europe, it is the law, so that in Europe, medications have to identify whether gluten's present or not. And I think it would certainly be the safest thing here. So that's one answer, but that's not going to happen today or tomorrow. But what you can do in the short run, there is a website, at least one website, that's run by a pharmacist only looking at gluten in drugs. And we'd be happy to get that information for that website. In fact, I don't know if I see Vanessa here or not, but yeah. But we can certainly supply that for people, and that's a helpful start. But I'll tell you, even with that website, the families who I think have had the best results have ended up calling the company to find out about whether gluten's present or not. And I think that's sort of the fail-safe. That's sort of the end of the line best answer. Yep.
Yeah, regarding Dr. Fasano's zonulin drug,
Yep.
is there any risk that we run the risk of becoming malnourished because we're somehow blocking our intestinal absorption of other proteins by taking a drug like that?
Well, it turns out that there's not a lot of uptake of regular healthy nutrients through those tight junctions. That's an altered state, to get those tight junctions to split open and have stuff come through. So I would say the short answer is no, because the uptake for almost all the nutrients is across those cells in the villi, those finger-like projections, and it comes through the cell, not through the tight junctions.
Question.
Yep. Sorry.
If a gluten-free diet is keeping me healthy, when these new drugs come out, is there any reason for me to take them? Would I, be helping myself, or would it be better to just continue my normal gluten-free diet?
We've had a series of awesome questions. It's absolutely great. So one of the first things I tell every family, I'm not much on prescribing medications. I'd like not to do that if I don't have to. So that's the way of telling you, if I didn't have to take a medication and I can do this with my diet alone, that's what I would do. And sort of an allegory to that, or an addendum to that, is that I tell families I don't ever want to tell anyone that they've got a disease. It doesn't give me any pleasure at all. But if I have to tell a family that their child has a disease, I'd rather it be a disease that they can treat with a diet and not have to take medications too. So that's a long answer to a very good question. I would say no. I wouldn't use those medications if I didn't have to. Yes?
Oh, there's one question back there.
Yeah.
Back to the issue of lots of diagnosis now of celiac disease. Do you know if there's anybody looking at doing studies starting with young women longitudinally, and then during their pregnancy, looking at all the factors, and then the rate of diagnosis of the children. Does that make sense?
Yeah, so like a population study looking at a person and then having them get pregnant and following their offspring, and these are people that have celiac disease that you're following, or just the population in general?
Well, you would have to have a, you wouldn't know who's going to have it.
Okay, so if you're looking at the whole population, then not a pre-selected population that like has increased risk for celiac disease like we talked about in those children in those studies that I talked about earlier, looking at the whole population, and there are data on populations like that. There's something called NHANES. It's a bunch of initials, but it's a federally funded project that's looked at health in an area of Massachusetts over a number of years in a big population of people. And they have data, including serology, so they have blood testing for celiac disease as part of that. And that has confirmed about that 1% rate of finding celiac disease in general populations. So I'm not sure if that's what you're asking, but that's a no.
Really,
Okay.
I'm thinking about that, what happens during a woman's pregnancy and maybe just prior to it has such a big impact on the health of her child. So is there anything looking at that, going a little bit further than when they're born?
And so you're looking at the development of celiac disease in that pregnant woman or in her offspring?
In her offspring.
In her offspring. So the I would say I'm not aware of a study like that, but if you sort of think through it in a, I hope a thoughtful way, I'm not sure that you would find much about that unless, so it's a disease that requires a couple of things. You have to have the genes, so the pregnancy itself and the delivery shouldn't really be a part of that. And then it needs a trigger, and that trigger is gluten and gliadin, and so again, the pregnancy really shouldn't be a part of that. So I think that's probably the best answer I can give you. I wouldn't think that those factors would probably play an important role in whether a child develops celiac disease or not.
We're going to have to wrap up questions to go to the next presentation. We're way over to keep the schedule. But if anybody has any further questions for Dr. Snyder, he'll be available outside of the room to be able to ask questions. We're going to move on to our next presentation. And